Good morning, good afternoon, buenos días, buenas noches. Welcome to this webinar called Medico-Social Integration in Primary Healthcare in the Post-Pandemic Era. My name is Baltica Cabieses. I'm a full professor at Universidad del Desarrollo in Chile, and I will be hosting this webinar today. Thank you for joining and thank you for staying tuned about this important topic. As a general context for this webinar, primary health care constitutes a fundamental socio-cultural determinant of health, grounded in core principles and serving as a central agent within communities. It plays a critical role in addressing complex global health megatrends, wherein effective medico-social integration is pivotal to the attainment of primary healthcare principal objectives. The COVID-19 pandemic further underscored the urgent need for transformative medico-social integration within primary health care, yielding significant lessons regarding health systems resilience, equity, and social responsiveness. The Lancet Commission on Transformative Primary Care in the post-COVID-19 era is centrally concerned with the development of an evidence-informed and globally relevant framework to fundamentally reorient primary healthcare systems. It aims to ensure that these systems are more equitable, resilient, people-centered, and capable of responding effectively to current and future societal shocks. Medico-social integration constitutes a core pillar of this framework. The Commission positions primary health care as the cornerstone of sustainable health systems and seeks to elevate its role in the aftermath of the structural disruptions and profound inequities revealed by the COVID-19 pandemic. As part of the Lancet Commission on Transformative Primary Care, this webinar seeks to disseminate the principal findings of an umbrella review focused on understanding and advancing medico-social integration within primary healthcare in the post-pandemic context. Over the course of this 60-minute webinar, international experts will examine global experience on medical-social integration, highlighting key lessons learned, ongoing implementation barriers, and outstanding challenges. The discussion will be complemented by 4 case studies designed to enhance practical relevance and to illuminate real-world implementation strategies and insights. This webinar has been organized by the Lancet Commission on Transformative Primary Care in the post-COVID-19 era, the University of Hong Kong in China, Universidad del Desarrollo in Chile, University of Texas Medical Branch in the US, and the Auckland University of Technology in New Zealand. I am extremely pleased and happy to be sharing with you this opportunity and the knowledge and evidence provided by this group of experts on this important topic today. I will immediately start with my presentation, which is around our work on the Lancet Commission on Transformative Primary Care in the post-COVID-19 pandemic era, and with a particular focus on the medical-social integration alignment. So as a context, the Lancet Commission on Transformative Primary Care in the post-COVID era is centrally concerned, as I said, on the development of evidence-informed and globally relevant framework to reorient and strengthen primary healthcare systems globally. It aims to ensure more equitable, resilient, people-centered, and with more effective responsiveness to current and future societal shocks. The Commission positions primary care and medical-social integration within it as a very important pillar. So we are aiming to advance through this webinar and the work conducted by this team for over a year now, advancing medico-social integration within primary health care in the post-pandemic context. Our general aim as a team was to unveil current global progress in medical-social integration for optimized primary healthcare outcomes, analyze unique case examples, and develop evidence-based recommendations. We opened and we started our work with four main key questions. How is the medical-social perspective being conceptualized, and how it varies depending on context? What are the key components and interactions required for effective medico-social integration? How can community health and social needs be effectively integrated in the design of targeted health promotion strategies and preventive services in primary care? And what is the role of public health in driving the integration between these services? The team, which I'm very proud to present today, was led by me, but followed by wonderful researchers who are Eleanor Holroyd from the University of Auckland University of Technology at New Zealand. She's a professor in nursing research, associate dean at the Faculty of Health and Environmental Health Sciences, and a co-director of the AUT Center for Migrant and Refugee Health Research. Also led by Professor Hani Serak at the University of Texas Medical Branch in the United States. He's the director of the Division of Global Partnerships, associate professor at the Department of Population Health and Health Disparities, and the School of Public and Population Health. This Lancet Commission, and as a part of this group, is also William Wong. He's a full professor at the University of Hong Kong in China, clinical professor and department chairperson at the Department of Family Medicine and Primary Care, Li Ka-shing Faculty of Medicine, chief of department and honorary consultant at the Hong Kong U Shenzhen Hospital. We also had the fortune to be working with four wonderful researchers: Howard Lee, also from the Hong Kong University, China, research assistant professor from the Department of Social Work and Social Administration member, Sao Po Center of Aging, Faculty of Social Sciences at the University of Hong Kong, Roxanne Fang, who was also a part of the University of Hong Kong, China during some time of the work developed by this group, postdoctoral fellow at the Department of Family Medicine and Primary Care at the same university, and Maxine Mai, also at the University of Hong Kong, China, research assistant at the Department of Family Medicine and Primary Care at the same university. I would like to very importantly thank the three of them for the wonderful work, their commitment, and all the time and effort put to this Lancet Commission and this group. So the umbrella review or review of reviews that I will be presenting now was also submitted and is available online as a protocol at the Prospero web page, which is where many reviews, systematic reviews, and review of reviews from all over the world are published as a way of producing clear ethics and supporting the evidence and rigor that is followed afterwards. I want to give you an overview of what we have been doing as a group for this Lancet Commission. It has been very intense, sometimes time-consuming, but very enjoyable work that was launched in March last year, 2024, and it started its work fairly around April, May 2025, and then we started as a group working with meetings every 2 weeks, and I think we have only missed one or two during the entire time, in which we developed the review of reviews. We conducted and developed the 4 case studies, completed the analysis, continued to add a full report document for the Lancet Commission, this webinar, and also the publication that it's being finalized now to be hopefully submitted by the end of this month. So as a context for this medico-social integration part of this Lancet Commission, it's important to say that primary health care is a socio-cultural determinant of health, grounded in foundational pillars and serving as a vital agent to the community. Primary health care is critical all over the world for addressing complex global health megatrends, and medico-social integration is so important within that. And we also need to look at how primary healthcare is being thought, understood, and implemented after the COVID-19 pandemic, given all the lessons learned for that important experience, challenging experience we all had globally. So for the review of reviews, we conducted it following the PRISMA guidelines of systematic reviews and meta-analysis. It was from systematic reviews and meta-analysis published in peer-reviewed journals between 2005 and 2025, which were searched in high-yield scientific database, the ones that appeared in the slide. It focused on patient care experiences, intersectionality, challenges and barriers, and facilitators, and also systematic drivers for medico-social integration in primary care globally. Two reviewers blindly screened and selected manuscripts which were available in the software Ryan for use of simultaneous publications and organizing the screening. And data was extracted following an Excel sheet that we developed and piloted before full data extraction, including the Quality Amsterdam 2 guideline for systematic reviews. Descriptive frequencies and narrative content synthesis was conducted for the finally 71 selected papers, with subgroup analysis by population and region whenever possible. Here you can see very quickly the search strategies that we conducted, and there is the example for PubMed, and they were replicated accordingly for the different databases. And here is our flowchart following PRISMA guidelines, where you can see the amount of hits we found first, the reasons why we were excluding some throughout title, abstract, and full text, screening process, and the final 71 selected papers. The dimensions we use for data extraction are the following: review characteristics, integration models, integration mechanisms, target population, patient and care involvement, elements or components, implementation strategies, effectiveness, facilitators and barriers, and contextual factors. So just to go quickly through our main findings, a total of 71 scientific articles were included in this systematic review, which were published over a span of 2 decades, as I already mentioned. 41% of them were Q1, first quartile, 22% were quartile 2, almost 7% quartile 3, and just 2% were quartile 4. Most reviews, 51 of them, synthesized evidence from high-income countries only, while 13 reviews included evidence from all income countries, and 7 only focused specifically on low and middle-income countries, showing a clear gap in knowledge and evidence in the high-income versus low and middle-income countries and contexts. Methodologically approach was largely quantitative with 36 of them, mixed methods with 19, qualitative 14, and non-specified 1. There was also 1 umbrella reviews, which was focused in Europe. Reviews varied considerably in the number of primary schools incorporated, ranging from single study reviews, which were only a few, to large syntheses including over 400 studies. Among them, 13 reviews conducted meta-analysis, with samples ranging from 667 participants to over 31,000 participants. The majority of the reviews focused on chronic health conditions, 59 of them, and only 1 addressed acute health programs, and 2 reviews examined both acute and chronic health conditions. In addition, 10 reviews did not specify any type of health condition. Here are beautiful maps developed by the research from our group, Maxine Howard, who did these beautiful maps to represent where the systematic reviews were coming from and the specific countries of studies included in them. So there you can see the first map in red, presenting from high-income countries, and the second one, which are very few, from low and middle-income countries. So in terms of definition and approaches, which was very important as a starting point for this review, medico-social integration is often conceptualized as an intentional, people-centered, multi-level strategy integrating health and social services to deliver continuous coordinated support. It aims to improve outcomes, experience, equity, quality of life, and systems efficiency. Through the 71 selected papers, two main conceptual frameworks or approaches came across us. The first one is people-centered models, and the second one, system or whole system models. The first one is focused on respecting patients' values, contexts, and cultures, including family-focused, dyadic, and culturally adapted interventions, the use of navigators to bridge systems. And the second one, emphasizing cross-level integration with shared governance, formalized communication, and intersectoral collaboration. In terms of the core components for medical-social integrations, the most important ones we found as we revised all the selected papers was first, multidisciplinary teams, second, integrated medical-social model of care, third, integrated and shared service location, and fourth, integrated governance and information systems. These four core components are at the center and heart of medical-social integrations, and selected systematic reviews constantly framed these four at the most significant pillars for effective implementation of medical-social integration in different countries and in different regions of the world. So they became very important for effective medical-social integration, especially in high-income countries, but also in low and middle-income countries. Which were the most important enablers and barriers that we found? We found three significant enablers for medical-social integration: policy and leadership, organizational structure and technical capacity, and communication systems. Policy and leadership are very important. They don't secure effective implementation, but there is no effective implementation without policy and leadership. You need them. You need them as the frame and context for medical-social integration and effective implementation. For organizational structure and technical capacity, you may have really good ideas, but if your people are not trained and they don't have the mindset for medical-social integration, they will not become the true bridgers and leaders for its effective implementation. And communication systems were, for a large amount of systematic reviews, extremely important. If you don't have formal channels of communication, if you don't have formal ways of mediating and solving problems, and if you don't have them to talk to each other, think of the medical team and the social team communicating and talking constantly, not just for problems, but constantly, effective medical social integration will not happen. As barriers, we also found three: systems and environment constraints, patient and caregiver challenges, and measurement and evaluation issues. Things like limited resources, service gaps, fragmented environments, but also stigmas, mistrust, and concerns about provider competence, as well as not having standardized ways for measuring medical social integration and care, are relevant barriers that neglect effective integration. In terms of effectiveness, integrated primary health services in these systematic reviews consistently outperform non-integrated care across health and social outcomes. This is a very important finding for our umbrella review. Integration of medical social care provides better care than fragmented social and medical care. And this was demonstrated through the systematic reviews in improvements of health status, patients' experience, service use, and equity across multiple areas, as those that are here in this slide. It also helps to reduce avoidable hospitalizations among patients with chronic diseases, moderate gains in depression, quality of life, self-efficacy, and social functioning. It also proved relevance for a number of health outcomes, such as for heart failure, for tailored interventions for HIV and AIDS, for community-based mental health integration. And of course, evidence remains limited or mixed for some unique health outcomes that need more evidence, like chronic kidney disease, certain adult cancers, and pediatric chronic conditions. So there's a clear gap for coming research globally in this topic. There are overall positive experiences for patients and carers about medical social integration. Patients valued empathy, respect, being heard, and shared decision making. And the use of different important elements like navigators, interpreter services, structured follow-ups, improved trust, and helped identify unmet needs. Navigation supports and goal-setting framework were also very important. What did the pandemic taught us as lesson learned for medical social integration in particular? It taught us about the significance and need of supply chain integration. This was shown during the pandemic for community-based and home delivery care, for PrEP and ART prescriptions for AIDS and HIV, for decentralized distribution point to ease system congestion for different prescriptions and service delivery. It proved the relevance of technology integration. Through the rapid adoption of telehealth consultations and monitoring, virtual care reduced access gaps during mobility restrictions, and digital tools shown to effectively extend the primary healthcare reach, especially for stable patients. It also taught us about human resource integration. This was so important during the pandemic, globally, in every country and region. Expanded roles for community health workers, peer educators, and lay counselors proved effectiveness to improve care in communities for primary health care. Peer-led support strengthened trust, adherence, and linkage to care. And human resources bridge clinical care with social and community realities. And also service integration. For example, for HIV self-testing, which promoted privacy, convenience, and reduced stigma, and demonstrated high acceptability, feasibility, and equity, enhancing potential. The pandemic can be and could be and was in many places a catalyst for change. It also provided cross-cutting insights on how primary healthcare can be strengthened, like the ones that are shared here in the slide. And also we have post-pandemic implications from primary healthcare reform, like institutionalizing innovations that were created there, but in many places have already disappeared. Build primary healthcare systems around adaptability, equity, decentralization, and patient-centeredness, and lessons learned from particular healthcare conditions, of course. There was limited evidence for low- and middle-income countries. However, evidence suggests context-adapted integration models were relevant. Despite few cases, they were relevant still. And some common core components that were useful, like disease-specific education and medication guidance, dietary and physical activity counseling, and lifestyle behavior change support. This is a map also produced by Maxine and Eleanor about the keywords for each of these elements that I just shared with you today. In terms of limitations, and I will start finishing my presentation with this. We, of course, conducted quality assessment. 43 reviews were rated as good, 24 as regular, and 4 were poor. Many studies had small sample sizes, lacked randomization, and used observational designs. There was a huge amount of heterogeneity. Methodological issues were also found in the systematic reviews. I already said a high proportion of them from high-income countries. Patient perspective, cost effectiveness, and implementation fidelity were often underreported or absent, and there were also inconsistencies in methodology and conceptual definitions. So, just to be finishing this idea, integrated medical social models outperform non-integrated services. Many interventions show cost savings and improve systems efficiency. Multidisciplinary teams are essential. Human rights, equity, intersectionality, and cultural relevance must guide models at all levels. And there are also gaps and challenges, such as persistent medico-social divide, lack of operational clarity in many places. Success depends on structured interpersonal education, evidence on gaps, especially in low-middle-income countries, feasibility barriers, over-reliance on best practice models, which might mismatch local realities in some countries, and ethical and data governance concerns were also raised. We produced 11 recommendations for medico-social integration within primary healthcare globally, based on these findings and our 4 case studies. This will be available on the full report and in the Lancet Commission in a few months' time. And with that idea, I just want to thank you for listening to me, and also, of course, coming back now to our panelists and experts, share with them their views and understandings. Thank you so very much. I will pass the lead on to Eleanor now, and she will be sharing with us her case example on New Zealand. Dear Eleanor, welcome. Thank you for being with us today. Thank you for all your exceptional work. Let me make you co-host for all your exceptional work in this Lancet Commission group, and the screen is all yours. Let me know if you can share your screen without problem. We are seeing something different.
Yeah.
Don't worry, we can wait for you. Maybe if you need me to, at some point, open your slides, just let me know.
Yeah, that would, oh, here we are. This should be sharing.
Yes, wonderful. Thank you.
Good morning, good afternoon, and good evening, everybody. Thank you very much, Baltika, for that wonderful presentation and for leading our team. That's wonderful to have you heading our team. It's my pleasure to present our findings from the application of the findings to New Zealand in terms of the case study of New Zealand. And I'm going to talk about transforming primary care in New Zealand, Aotearoa, in terms of medical social integration, using the findings. Aotearoa, New Zealand, is a high-income country in the South Pacific with approximately 5 million people. It's bicultural, strongly founded on a Treaty of Waitangi, and tangata whenua Māori, our Indigenous population, comprises of about 17%. The cornerstone of New Zealand is primary healthcare context, and we have a number of acts that have made that centralised. However, while life expectancy has increased, persistent inequalities exist, particularly in chronic illness such as cardiovascular disease and diabetes, which disproportionately affects Māori population and Pacific populations with lower life expectancy compared to non-Māori and Pacific. We have a number of key health diseases that impact upon New Zealand healthcare, and particularly our primary care remains strained by workforce shortages and rural access issues and under-resourcing. So as a result, nurse practitioners have become increasingly instrumental in addressing health inequalities in the landscape. They were first introduced in 2021 to improve health access for priority populations such as refugees, Maori Pacific, rural and remote. Their qualifications include a master's degree, 4 years clinical, post-clinical graduate practice, and they're also registered under an act. Currently today, there are over 800 nurse practitioners practicing, with initiatives to further train nurse practitioners and increase the role in all capacities. Nurse practitioners challenge biomedical hierarchies through person-centred and whānau, which means family-centred care, grounded in Mataranga Māori, which is Māori wisdom, Māori knowledge, and lived experience, as well as leadership. Transformational leaders driving systematic reform for operationalising our treaty for cultural brokerage and co-design. They work across sectors, across lifespan, and many of them come from kaupapa Māori healthcare providers. So it's bringing alongside our Māori healthcare advances and admissions. And they've led to improvements in preventive care, reduced hospital admissions, and increased access for high need patients. They've also got a key role in leadership, particularly in responding culturally and responsibly to diverse populations and redistributing clinical authority. They're uniquely positioned by working alongside social workers, public health, nurses, and navigators. Our key focus is advancing health equity for Maori Pacific populations, strengthening continuity of care, importantly, and community connection as a result of lessons learned in the COVID era, and particularly digital health innovations. Expanding public health leadership, supporting disaster preparedness, community resilience, and planetary responses in the context of climate change. One of the key foci include targeted investment in governance, which was a key part of our findings about systems alignment, mentorship, educational models, and representation in healthcare decision-making. So by linking expertise with responsiveness, political advocacy, they can close the medical social gap that continues to fragment primary health care. And their leadership is vital to realising a cohesive, equity-driven system that integrates health across and well-being across primary healthcare sector in New Zealand. So I'd just like to finish there and thank everybody for listening.
Thank you so much, Eleanor, for going in a very effective management of time through a very interesting case study about nursing empowerment in New Zealand and how positive and relevant that can be for transforming primary health care generally, but also for medico-social integration. Thank you so much. We will now move on to our dear colleague, Hani Sarek. He will be presenting the case of the US. Dear Hani, welcome. It's wonderful to have you today. May you please start sharing your slides just to check if we can see them correctly? And thank you for being here with us, sharing about medico-social integration in primary healthcare in the US. The screen is all yours. Thank you.
Thank you very much. Do you see my screen?
Yes.
Great. Thank you very much. I'm presenting a case study on the medico-social integration in primary healthcare in USA. Just a very quick introduction. The medico-social integration refers to structured coordination between health care delivery and social service system. So this is the definition adopted in this case study. And this is to address non-medical factors such as housing, food security, and transportation. While the US is talking a lot in literature, in academia, in policy documents, and so on, about the socio-medical integration, there is, in the real implementation, remains fragmentation between the medical services and the social services. So the whole person care approach is really remain theoretical in the US context, but not into implementation. The National Academics of Science, Engineering, and Medicine also emphasizes without unified governance, shared accountability, and infrastructure that can be shared, the integration will remain theoretical. It will not be into real implementation. So we will talk very, very quick about few categories of barriers to socio-medical integration in the US at the primary healthcare level. We will try to cover structural and systematic barriers, the organizational and operational barriers, barriers related to the professions, and barriers related to data and evidence, and also patients and community. Starting with the systematic barriers and policy. So there is massive fragmentation in the US between the social services and healthcare services. Also, the fee for service payment model, the whole system of reimbursement of providing care and reimbursement is one of the major barriers to the integration. The limited insurance coverage for social interventions. So again, while there is lots of literature and lots of value propositions in the US about the value based reimbursement and value-based care, is still the reimbursement to great extent for medical procedures. So it doesn't cover any kind of long-term or integration of social services. Also, the lack of policy alignment. Federal and state regulations are different across healthcare. And one of the good examples of that is Obamacare or Affordable Care Act. So while it is a federal policy, it's not fully adopted in different states. And one of these states elect not to implement it is Texas, where I'm living at the moment. Workforce shortage, and there is a lack of trained workers who can play the role of this integration. Health professions is lacking lots of people, physicians, nurses, and so on, but also the social workers. And one of the major barriers I see is the lack of the integration of community health workers into the system. Organizational and operational level, there is absence of data system that integrate data about social determinants of health. Also, there is a poor definition of referral pathways. We do not have the referral system from between medical and social services, limited cross-sector partnerships, and also the staff worked still do not see the value of this integration, and there are sustainability issues. The culture is still one of the major barriers, is the dominance of the biomedical approach. So the social integration is not just difficult to implement, but also in many cases, it's not perceived as important. For data, again, there is no standardization for integration of health and social data. And at community level, it's very important to talk about mistrust and stigma, but also the access barrier. One of the big examples in the place I'm living in south of Texas, transportation continues to be one of the real barriers to access healthcare services. So I will stop here, and the presentation can be available for whoever wants. Thank you very much.
Thank you so much, Hani. That is a very clear and robust way of describing the numerous and complex barriers to primary healthcare medico-social integration in the US in contexts and times that are also complex in many levels globally. So thank you for that, and I'm sure that afterwards for the Q&A section we will be able to discuss further these elements. I will now invite Maxine to come to the screen, please, so that she can share with us her case example on mainland China. Dear Maxine, thank you for being with us today. Thank you for your amazing work in this group on medico-social integration in this Lancet Commission. And the screen is all yours. Thank you.
Okay, thank you, Latika. Can you see my screen?
Yes.
Yes. Okay, thank you, Latika. And sorry. Good morning and good afternoon, everyone. Today, I want to share a case example from the mainland China, focusing on the community-based medical social integration model known as the family doctor plus community great worker model. And China is currently based in facing the dual pressures. Dual pressure? Yeah, face the dual pressures of the rapid population aging and the growing burden of the chronic disease. In response, the government formally introduced the Family Doctor Contract Service Public in 2016. aiming to establish the family doctor as the primary healthcare gatekeepers for the residents. However, in the practice, the medical system alone struggle to reach the high risk and hard to engage population, such as the isolated older adult living in the community. So the family doctor often lack the fine grained knowledges of the residents' daily lives, while the community lead extended far beyond clinical care. So this gap create the condition for a new form of the integration. What we call is the family doctor plus grid worker integrated care model. So what's the community grid workers? They are formal government-funded contract employees. They originate around 2005 in the major cities like Beijing and Shanghai, initiatives for population management and public security. Each Greek worker is responsible for a fixed geographic area, usually 300 to 500 households. Through the daily processes, they develop what is often described as the living community map, detailed practical knowledge of who lives where and who may need help. And their role is to support the information flow, service connection, and trust building. For example, by assisting residents with the family doctor enrollment or expanding how to access the primary healthcare and social service. And the COVID-19 pandemic becomes a critical turning point of this integration. Because during the strict lockdown, the key challenge was not the medical knowledge, but the physical and social connection. How to deliver medicines and maintain the continuity of the care in a frozen city? The solution came from the existing community Greek worker network. And the Greek workers leverage their deep familiarities with the building and the households to organize medicine and food delivery, and they help to guide the mobile medical teams and act as the trust interface between the top-down policy and community realities. This experience circulates the formal integration of the Greek workers into the primary healthcare teams. And this model shows three major strengths. First is the cost-effective and scalable, as it builds on existing governance structure rather than creating a new workforces. And second, it already achieves a high engagement and trust, and continuous and the continuous and localized interaction is valuable for aging population and chronic disease management. Third, it supports the earlier prevention, enabling earlier identification of the issues such as the social isolation and facilitating the timely reaches to the medical or social service. And also, this model has some challenge. First, there are role overlap between the grid workers, social workers, and community nurses. When the roles overlap, tasks such as follow-up, outreach, or social support might be duplicated. This can increase the transaction cost and create a confusion for both providers and residents. Second, the funding and workforce stability are uneven across region, especially in the low resource area. Third, there are still concerns about the keeping service quality and ethical standards consistent, particularly among the part-time and less trained grid workers. So in conclusion, this model, the grid worker joined our primary healthcare team initially under the emergency condition during the COVID-19, but as the integration become routine, it really highlights the importance of governance, training, and clear roles of their long-term sustainability. That is all my sharing. This is all my case study.
Thank you so much, Maxine. That's really interesting. And it's always incredible the size of how implementation looks like in China. And this is taking mainland and a huge amount of territory and population. So it's fascinating to see. Thank you so much. I will now very briefly share with you a case study on Chile. So I'm going to share my slides first. I'm going to go very quickly through an example of the intercultural health integration with indigenous healers and migrant communities in primary health care through the PESPI, a national program in the post-pandemic era. So in Chile, primary health care is very important and it's grounded in relevant principles of equity, transparency, participation, and resilience. And in the 90s, it was developed a very special program called PESPI for the Spanish Programa Especial de Salud de Pueblos Indígenas, which continues up to today and looks specifically at three unique indigenous communities, Mapuche, Aymara, and Rapa Nui from Easter Island. And this has represented for all these decades a transformational approach to medical social integration through intercultural health in particular. This experience also led and supported the National Health Policy for International Migrants developed in 2017 in the country. The PESPI national program is held by four elements. Of course, the overarching goal, but also some several key components, levels of action, and expected health outcomes that have been monitored throughout all this time. PESPI has been assessed despite some criticism from different parts, different experts, different voices of its limitations and challenges. It has been recognized as a very positive program for medical social integration with indigenous communities, visions, cosmologies, and ways of living and understanding how the mind, the heart, and the body can be healed. And it has been adapted to over 35% services in the country between 2010 and 2020. Patient satisfaction surveys has said that PESPI has over 80% of rates of satisfaction compared to national average for primary care, which runs around 65-70%. Additionally, it has improved timely access to maternal and child health services for indigenous communities to up to 25%. During the pandemic, the PESPI continued and it identified a critical cultural interpretation of the National Health Directive to stay home. So some indigenous communities interpret home as their communities, not just their houses. So through the PESPI program, this different interpretation of the general recommendations was understood and it was effectively promoted through sensitive communication strategies as curfews were ongoing in the country. And after that, the sense of home as communities was preserved once the pandemic was at a different stage of it and starting to finish in the country. And so the identity of communities was preserved for these Mapuche communities in particular. Despite its limitations, PESPI remains a critical model for decolonizing healthcare and advancing equity in embedding indigenous cosmologies into the heart of Chile's public health strategy. The PESPI model promotes transformative primary healthcare that not only serves indigenous populations, but also enrich the national global primary healthcare landscape in the region and for migrant and refugee communities afterwards. So that's what I wanted to share with you very briefly about the case study in Chile. And now I will pass the word to Eleanor, who will be leading the Q&A section of this webinar through an engaging conversation with our experts. So I also invite our experts to turn their screen on so that we can have a live conversation in the next few minutes. Eleanor, maybe you could pass on to Howard first for his words, and then we can, from that, take it on to the Q&A. Thank you.
Go ahead, Howard, won't you?
Okay, thank you all. Yeah, and thank you to the organizers and presenters for this insightful webinar on medical social integration in primary healthcare. As we, I would like to offer some comment that reflect on the key themes from the report, drawing out the implications for practice, policies, and future actions. I will aim to keep this concise, focusing on what stands out as formative in this post-COVID era. First, the report powerfully affirmed primary health care's role as a social cultural determinants of health, a foundational agent for communities, not just clinical services. We know from the ELMA, ATA, and Astana Declaration that primary healthcare is about equity, participations, and addressing upstream factors like poverty and cultural barriers. The evidence here builds on what showing how medical social integration bridge medical and social service to tackle global mega trends. Migration, like migration, aging populations, climate change, infodemic inequities, and political polarizations. These aren't isolated issues. They are interconnected syndemics that primary healthcare must confront holistically. And what excites me most are the new insight from the umbrella review and case examples. Medical social integration isn't abstract. It is a multi-level strategy with concrete components, multidisciplinary teams, shared care models, co-located services, and integrated governance and data synthesis. The literature highlight enabler like strong leadership, policy support, and communication channels, while barriers like environmental constraints, stigma, communication gaps remind us of the real world hurdles. Crucially, integrated primary healthcare yields better outcomes like improved health status, patient satisfaction, equity in mental health and geriatric care, and even cost savings through reduced hospitalizations. And the COVID-19 pandemic, as we discussed, was a catalyst for change. It accelerated the medicalization and community-centered innovations like multi-month dependence and telehealth in HIV care, showing how integration across technical human service domain builds resilience, but it also exposed gaps like a fragmented response, left vulnerable groups behind, and underscoring the need for continuity by design and emergency-ready pathways. Post-pandemic, we can't revert to silos. We must institutionalize these lessons. Yet challenges persist. Um, we know that methodological limitations in the reviews, like small samples, heterogeneities, and bias toward high-income countries. Feasibility in low resource setting is a concern. So a best practice must be tailored, not imposed. Data privacies, ethical issues in sharing, and the need for an anti-racist the colonial lens are non-negotiable. So opportunities lie in addressing these, centering indigenous knowledge and cultural diversities and underserved population can make integration truly equitable. So in last but not least, I was saying that um, this review is not just a synthesis, it's a call to action. Primary healthcare must evolve from a reactive system to a proactive integrated force for health justice. By embedding medical social approaches, we can build resilient systems and leave no one behind. So let's commit it to implementing these recommendations and starting with local adaptations and global knowledge sharing. Thank you for this engaging discussion. Thank you.
Thank you, Howard, and thank you to the case study presenters. Very informative and fascinating. In the time we have left, it's my pleasure to ask a couple of questions. And I think it's a great note that you finished on, Howard, call to action, because my question is about action. Given our evidence that socially integrated primary healthcare outcomes work, what are the most critical system level changes, for example, policy, workforce, governance, required to move pilot models forward to sustainable, scaled implementation, particularly in low and middle income settings? And I think that leads very nicely into your final slide. Hannah, if you'd like to go first, followed by Maxine. Thank you.
Yeah, thank you, Ellen Lawrence. And I think they're both important, the policy, financing, workforce, and governance. But I think the most critical issue is actually the workforce based on the Chinese example, especially in the low and middle income setting. Like in pay where the Greek worker have worked well, a key reason is that they were formally brought into the system, pray regularly and given the care roles. So meaningfully to connect the people to the service and support their coordination rather than to replace doctors. So without this shift, the integration tend to remain the project based and hard to scale. So I think the critical issue is the workforce.
Thank you. Hanny.
Yes, thanks, Eleanor. I mean, from my perspective, the most critical issue is to get back to consider health as a human right, not a commodity. As long as we make health subject for profit and for capital investment, there is no way to implement this kind of integration. So I think it's not just systematic approach to dismantle the barriers for this integration, like policy cohesion, like operational plans, and so on, but also ideology. So we need to be confronted that health is a commodity or a right. And the implication of this agreement is huge, not just on the integration between social and medical systems, but also the whole definition of health. If we get back to the Almaty Declaration and talking about health as a fundamental human right and the fulfillment of the highest level of health is the responsibility of the government. Without these two big dimensions, like we have a claim holder and a duty bearer. So this is the human right language we can understand. Without these two pillars, systematic barriers will continue not just to be there, but to be recreated again and again and again. Thank you.
Thank you very much, Maxine and Hanny. So what we're hearing there is large-scale ways of thinking and conceptualization around human rights and getting back to early declarations that bring everybody together. And for Maxine, of course, around the importance of workforce and equity and fair pay. We have a few minutes left. I have one final question before we wrap up. One is about how we might get this into action and how we might actually make sure we centre the word social and integration. And I'll ask this question to Howard Baltika, and if there's time, I'll answer it myself. How can primary healthcare systems meaningfully operationalise social determinants to ensure that community knowledge, lived experience, and cultural values actively shape medical social integration in everyday practice? Would you like to comment first, Howard, please?
Oh, thank you for the question, Ainano. I understand that different scholars may have different approach, and based on my own research, and I prefer approach like a bottom-up approach. and especially adopting innovative methods like crowdsourcing and designathons to draw or collect ideas from the general public, from different key stakeholders from the public, so that we can develop solutions to address these issues. That's my point. Thank you.
Thank you so much, Eleanor, for that great question. I fully agree on Howard's point on improving social participation and integration from grassroots efforts and ideas, because the people who are living in those communities actually know the everyday and have a high quality of evidence of what is required, what's unsolved, and they need to be heard. So that's so important. And I would like to add two more things. One, I'm thinking of low and middle income countries in particular, and of models of mixed care with public and private segmentations and fragmentations, which are many in the world. The first one is thinking again of a mindset for individuals within healthcare systems of a medical social integration. So how we are teaching this, how are we creating competences in our healthcare workers and social workers to promote effectively through them, so that they can have in their bodies and in their mindsets the idea of medical social integration as a cornerstone, as a pillar. I think that's a big gap still. Many can be done with the same amount of money, and over time you can even save it if you do this effectively. And the second idea is about thinking on social determinants of health, community health, structural dimensions of health and healthcare, beyond the healthcare system's walls. So to think of healthcare, primary healthcare in particular, as one more agent of everyday life in communities, and not as something that comes from outside the community to, from top to bottom, provide care, but more than it's one part of the same chain. It's one element and component of the same community and society. It's really important so that we can think of healthcare, primary healthcare and health systems, as a part of something bigger and not as the heart of everything and the center of everything. And those two elements change completely the way you think and relate to others within healthcare and outside it. Thank you very much.
Thank you very much. And just, I'd like to expand on what's just been said by Howard and Baltika to summarize and suggesting that this is a larger issue. It's linked to human rights, as Hanny quite rightly said. It's linked to ways of viewing. It's linked to workforce. It's linked to lived experience, and particularly importantly, possibly how we value social knowledge in schooling and in primary schooling, secondary schooling, and in communities, and having that deeper understanding embodied in our systems that actually makes that able to be transformed. So I'd just like to, I've got the pleasurable role of saying thank you to all our wonderful presenters and to the team for their absolutely awesome work, and for Baltika's leadership in the team, and for the opportunity to be part of this webinar on behalf of the team. So thank you very much for your time. It's been a pleasure being part of it.
Thank you, dear Eleanor. Thank you, everyone. This is the moment to finish our webinar. Thank you for staying with us. This will be available in YouTube and UDD TV channel for others to see afterwards. And for those who do that, thank you for following this conversation. And we hope to see you later on in the next few months as the Lancet Commission report and related papers come live to the world. Thank you very much, everyone, and have a great day.